everyone. I am Dr. Deepak Talwar. I am Secretary, Indian Chest Society, and I am a pulmonologist working at Noida Metro Center for Respiratory Diseases. There is an association between API and ICS to provide respiratory updates to physicians, and it has formed a body called EPICS. EPICS webinars are coming your way, and considering the high interest and emphasis on the lung health in the current times, this is going to be a monthly series. Twice a month, it will be coming on 2 Saturdays, and it aims at providing a complete update on advances and diagnosis of management of some of the respiratory diseases which are of importance to our physicians as well as respiratory physicians. This will be based on case-based discussions and what we routinely encounter in our daily practice. So this webinar is going to be a great way to help us enhance our knowledge to treat our patients. And of course, this seminar is aimed at not only physicians but also respiratory physicians, and hence we'll have mix of physicians as well as respiratory physicians discussing it on the table and giving the messages which can be implemented in our daily practice. So do join in for this EPICS webinar, which is going to be on 11th March, 8 p.m. onwards. And the knowledge partner for this is Glenmark.
Hello everyone, it's my immense pleasure to welcome you all on this API ICS Respiratory Update online series. API and Indian Chest Society have joined hands to pursue the common goal to update the knowledge of respiratory physicians and practicing physicians in the field of respiratory medicine. There has been a spurt recently in respiratory cases and post-COVID complications, and a need was felt to update the knowledge of practicing physicians at a grassroots level. And I hope this online series of respiratory update will go a long way in achieving this goal. We will organize these programs at a regular basis as a case-based discussion, and will invite distinguished faculties to share their knowledge and skill. I compliment and congratulate Dr. Deepak Talwar, Secretary, Indian Chest Society, Dr. Jyotirmay Paul, Dean, Indian College of Physicians, and Dr. Agam Vora, Secretary API, for taking this wonderful initiative. I welcome you all again this evening and extend my best wishes for this program.
Welcome all the delegates. I am Professor Dr. Jyotirmay Pal, Dean, Indian College of Physicians, that is the academic wing of Association of Physicians of India. I welcome all the physicians and students to this joint symposium of Association of Physicians of India and Indian Chest Society. It is my intention to enable different associations to come together and organize such collaborative endeavors for the advancement of knowledge and mutual exchange of wisdom that will ultimately lead to upliftment of standard of medical care. Hope this joint symposium of Association of Physicians of India and Indian Chest Society will update our members on the recent advances on respiratory medicine. Jai Hind, Vande Mataram, long live API, long live Association of Chest Society. Thank you.
Yeah, sure, no problem.
Good evening, everyone. I welcome you all to this series of APICS webinars. And today we have the second part of community-acquired pneumonia, where we will be discussing the management in 2023. We have with us a very illustrious panel and a group of case presenters. So Dr. Deepak Talwar, who is the director of the respiratory disease at Metro Hospital, Noida, is going to be our moderator for the session. And I must tell you all that he has been the brainchild from the Indian Chest Society for conducting these webinars with the API. So we must applaud him for that. We have with us Sushmita Roy Chaudhary, who is a senior consultant at the Fortis Hospital. She is also heading the pulmonology section at Fortis. I welcome Sushmita. Hi. And we have with us Dr. Saurabh Jain, who is a physician at HN Reliance Hospital, Mumbai. And we have our two case presenters, Dr. Rahul, who is a senior resident in medicine at Bombay Hospital, Mumbai, and Dr. Tanya Athavle, who is the senior DM resident at the KEM Hospital, Mumbai. So we start with our case. Tanya, you want to take over?
Yes. So this is a case of a 74-year-old female who presented at the clinic with chief complaints of fever for 3 days, which was associated now with chills for 2 days, cough with scanty expectoration for 3 days, and now she had increased cough with production of mucopurulent sputum. She had complained of shortness of breath for a day, and her attendant had noticed that she seemed confused the day she presented to the clinic. In past medical history, she had diabetes mellitus for 25 years and was in oral hypoglycemics for the same. But despite her treatment, her diabetes was not controlled with a HbA1c of 8.3%. She also had history of bilateral osteoarthritis of the knees, for which she was taking NSAIDs. There was some history of likely allergy to penicillin. On examination, the patient was conscious but was disoriented to time and space. She was thinly built, was febrile with a temperature of 38.4 degrees Celsius. She was tachypnic with a respiratory rate of 36 breaths per minute, hypoxic with a saturation of 86%. On respiratory system examination, she had an impaired percussion node in the infrascapular region on the right side and corresponding bronchial breath sounds. She was tachycardic with a heart rate of 120 beats per minute and had a systolic blood pressure of 92 and diastolic blood pressure of 54 millimeters of mercury, and her abdomen was mildly distended. So in risk stratification, according to the CRP65, she had a total score of 4 with age of 74 years, confusion, tachypnea, and a blood pressure of 54 millimeters of mercury diastolic. Her chest radiograph done in the emergency room showed a right upper and mid zone inhomogeneous opacities, which was suggestive of consolidation. So our first question is, where should we admit this patient, in the wards, in the high dependency unit, or in the intensive care unit, and how do we decide?
So, Pratibha, whom do you want to take this question? Dr. Shushmita or Dr. Rahul? Oh, sorry, Dr. Saurabh.
I think Sushmita can take this question.
Yeah.
Yeah. So when we talk about guidelines and we talk about patients coming into hospitals, we are not just talking about tertiary care hospitals. We are talking about any hospital in general. When a patient arrives with the simplest of risk stratification scores, we are able to take the patient in. So as you just showed, CURB 65 score is a good score to know whether to treat a patient at home versus treating a patient in hospital. So CURB 65, this patient has 4 out of 5. So we will definitely want to have this patient in hospital. Now, in hospital, whether you want to treat the patient in the wards or whether you want to treat the patient in a monitored bed is where, as you've put it up over here, that patients can be risk stratified with, a scoring system based on their comorbidities, whether they are currently comorbid, whether they are chronically comorbid or not, and whether they could be at risk of having difficult infections. And then that is where you would want to treat. Your patient here is elderly. Your patient has a CURB 65 of 4. She is tachypnic and she's confused. So I would definitely want this patient in a monitored bed. Whether it's an HTU or an intensive care unit can be assessed on the go while the patient is in the hospital.
Great. So moving forward, Tanya, what did...
Yes. So the patient got admitted to the ward, and basic lab investigations were sent. So she had a hemoglobin of 11.3 gram %, a total WBC count of 13,300 with neutrophils of 65%, lymphocytes 31%, normal platelet count 1.56 lakhs. Her CRP was elevated at 13, random blood sugar was raised 213 milligram %. Renal function tests, including electrolytes, were normal. Liver function tests were normal. Her sputum for AFP was negative, and urine routine corresponding to the raised random blood sugar had sugars present. Her sputum was sent for gram stain and culture, and a blood culture sensitivity was also ordered. So in IPD management, the patient was admitted to the non-ICU setting, that is the ward. Then because she was hypoxic, oxygen monitoring was done and oxygen supplementation was started. Her blood glucose monitoring was done and she was started on insulin therapy, and a tablet paracetamol 650 milligrams was advised SOS for the fever. She was also given empirical antibiotic therapy. So our next question is, how do we decide which antibiotics to choose to treat this hospitalized patient?
Okay. So we already have a slight discussion that we can take forward based on where this patient got admitted. I think some of us will be divided about ward admission versus, as Sushmita said, monitored HDU kind of admission. Well, this patient did get admitted in the ward. So Saurabh, how would you like to treat this patient?
Is there an issue with his connection?
Probably.
Saurabh, you are mute. Now you are mute, Saurabh. Unmute yourself.
Saurabh, you're on mute. Can you unmute yourself, please?
Hello.
Yeah, you are audible. Go ahead.
I think if there's a problem with his network, maybe Sushmita, you can.
Yeah, sure. So basically, this is somebody who is likely to have a community-acquired pneumonia, coming from the community, and unless there was any, the patient had reaction to or was hypersensitive to beta-lactams, beta-lactam would be our first choice, and along with that, add an atypical cover, which would basically mean a coamoxiclav plus azithromycin or a clarithromycin. If the patient was unable to take macrolides, then I would add a doxycycline instead.
So I think, Pratibha, a very good point which is seen here is that the choice of antibiotic at the time of admission in the hospital has to be empiric, because we do not have methods to do it. And just to recapitulate what we did in the last, which was the webinar was on the diagnosis of community-acquired pneumonia. Right now, we do not have any guidelines to suggest to use molecular diagnostic test for it. And the community-acquired pneumonia, we do not suspect the resistant organisms, so they need to be treated empirically. But once they are admitted, their sputum cultures have to be sent. So that is in the guidelines, that at least that much investigation should be done, and empirical antibiotic is to be chosen. So one more important thing for people who have not joined before, I would like to tell them that in the last episode, what was discussed is, on a clinic, when you see a patient with a respiratory symptoms and fever, how do you decide whether he has a pneumonia or not? And that was the most important point, to see that you have systemic features like fever and malaise, lethargy, things like that, sore throat, those things. You have respiratory symptoms along with it, like cough and sputum and pleurisy.
I think he's also got logged off.
Yeah.
Yeah. Okay. So basically, there will be cough with purulent sputum. There could be a history of comorbidities, basically, and you would either respiratory or other systemic comorbidities. And you will have to look at, evaluate the patient if needed, get a radiograph done to confirm the diagnosis of pneumonia, and then go
Just but
forward.
clinically for this. So I think I also dropped out.
Yes, so we
Yes,
just
yes.
completed a little bit of your recapitulation.
Right. It's done. So if we have done that, what we learned last time was that the combination of all three things together with an X-ray, and the moment you diagnose X-ray, you need to assess whether you can treat the patient in OP or you need to send the patient to the hospital. And the ER will be looking after where to localize the patient. And the important question which came was that how do we decide that this patient needs to be sent to ICU or HDU or to the wards? And most of the times it depends upon the whether we are in the public sector or in the private sector. Things would look different because ICUs may be over flooded, and many times they might land up into the wards where the patient might have been much better looked after in the intensive care like this. But the second important aspect which has come out very clearly is the choice of antibiotic does not depend at this moment of time, particularly because this patient is for the for the hospitalized admission, where you need to give him an intravenous antibiotic. And empirical antibiotic of choice, which very rightly is we are looking at beta-lactam and combining it with the to cover for atypical and a macrolide, or if macrolide cannot be given, then doxycycline. And this is what is the guidelines which have been published in the Blue Journal in 2019. And I think from there onwards, I think Pratibha, you can take forward. You are mute, Pratibha.
She has read my mind.
So the next question is, how do we decide whether to choose macrolides or fluoroquinolones, which is the other option, to treat hospitalized cat patients?
Yeah. So, Sushmita, you want to take this question, please?
Yes. So I think fluoroquinolones in our country's context has taken a lot of flack about we need to save it, we need to avoid resistance, etc. Fluoroquinolones should never be the first line of management unless you have, sensitivity guided patterns. When you're choosing antibiotics as empirical treatment in our country, macrolides always come first. However, if you have a definite sensitivity pattern before starting off treatment, and it shows that it is sensitive to fluoroquinolones alone, as well as if the patient has low chances of having associated tuberculosis, that's where you would choose a fluoroquinolone over a macrolide. And secondly, if the patient has reactions or is intolerant of a macrolide, and there is low chances of the patient having fluoroquinolones, that is where you would choose a fluoroquinolone in our country's context, not as upfront empirical treatment.
Right. Saurabh, are you there? Because I think this question is very important from the physician's perspective also, where levofloxacin seems to be a very good choice to treat these patients, and especially the guidelines in the US and the rest of the world do recommend to use levofloxacin. I think Saurabh, if not there, then Pratibha, I think you can
I think he's got logged off. So the interesting thing is that there are some studies which have shown superiority of a combination of fluoroquinolone versus a combination with a macrolide, and they have not shown any such superiority of the combination other than the specific conditions in which Sushmita has already mentioned. So I don't think, as a routine we should start, and in our country especially, we've seen that there is a lot of community-acquired pneumonia due to tuberculosis, which presents like an acute episode and a bacterial infection, in which if we start delaying the diagnosis to, in a community-acquired pneumonia setting, and there is an increased chance of resistance even in as short a therapy as 2 weeks quinolones. So I think in our country specifically, the thing should be that we should avoid giving fluoroquinolones as an empiric drug of choice unless there is a very strong reason, as Sushmita has mentioned.
So Indian guidelines very strongly desist from using fluoroquinolones for two reasons. One is, of course, tuberculosis masking, and second is obviously because it's a reserved drug for resistant tuberculosis.
Yes.
Both the points are there. So I think this is a message which we need to propagate to all physicians that this at least fluoroquinolones are the ones which needs to be restrained from using in treatment of pneumonia. I think that was the idea of even showing the Indian guidelines have taken also very strong wordings on not using fluoroquinolones to treat, although it looks very tempting, especially it looks very tempting easily, and especially in OPD based treatments, hospital based treatments, it's easy to use it. Yeah.
Just one more point. When fluoroquinolones are used, especially levofloxacin, it's always, I've found, used in a slightly lower dose than what it should be given. So usually for pneumonia, the dosage is 750, not 500, but mostly they'll come low dose and unindicated empirical treatment, which, as you said, should be avoided as much as possible.
Correct.
So the next question is, how do we decide whether to cover for Pseudomonas or MRSA to treat hospitalized CAP patients?
Do you want me to take it?
Yeah, please, Sushmita. I think Rahul is trying to log in.
Yeah. So first and foremost, let's do quickly away with the MRSA. MRSA, as much as is described in the in the Western population, I'm sure all of you will agree that in our country's context, we don't see MRSA per se in community-acquired infections, but some people who've been, on solid chemotherapy, have been in and out of hospital, or are living in a very closed, recurrent, hospitalized sort of community are the ones that are at risk of MRSA, and they should have a sample taken off before you actually give them MRSA cover. But Pseudomonas is way more easier to find in the community, also in patients who have, especially our respiratory patients who have, chronic bronchiectasis, those who have COPD and having recurrent infections, those who have pre-existing cavities, etc. These are patients who have pseudomonal, colonization. And as we all know, Pseudomonas forms a biofilm and is really very difficult to get rid of, and these patients keep coming in with exacerbations, especially in those who have pre-existing lung disease as well as bronchiectasis. These patients should have dual anti-pseudomonal coverage rather than one, and should have at least 10 to 14 days worth of antibiotics rather than 7 days.
So I think point has been very well clarified by Shushmita that unless and until there are risk factors to have Pseudomonas and MRSA, in fact, it's become a routine habit in the ICUs to cover for Pseudomonas as well as MRSA for every patient, which is really not required, because the spectrum is not different whether it is CAP or whether the CAP is in the ward or CAP is in the ICU, unless and until there are risk factors. And the new guidelines have even mentioned that, even risk factors, more important than risk factors is if there is a previous isolate in the last 3 months of one of these two organisms. That should be perhaps, point where you can take a call that, okay, if this is there, then I need to cover Pseudomonas, I need to cover MRSA. MRSA, obviously, I think Shushmita has made it very well, unless and until the patient is Burns patient has got kidney disease, on dialysis and things like that, those who are on a continuous parenteral nutrition, there are those very specific patients. But Pseudomonas, yes, chronic respiratory disease is the most important thing with the structural damage to the lung, where you really need to cover. So actually, we don't need to use triple antibiotics to every patient who gets admitted in the ICUs or ward ICUs, wherever we put them, unless and until there are factors. So triple therapy means that you are using beta-lactams and you are using macrolides, and you have to add another one, and that is for the anti-Pseudomonas cover, which is required. and maybe MRSA cover if your patient is of that group. But again, the guidelines are very clear that if you are doing all this, you might take samples very, very diligently in these patients, because the future therapy is to be guided into them, because they may not actually show that growth and there will be abuse of antibiotic in those patients. And that happens even in the wards, actually. Sometimes, by the sheer the blood pressure of the patient or the saturation of the patient or the look of the patient dictates the physician to take a call where you can actually go a little overboard. But then you must be taking samples in those patients, so actually very, very clearly recommended that these samples needs to be taken at this point of time, and that's something which is need to be kept in mind, right?
Great, Sushmita and Dr. Talwar. I think one cannot not say that. If you see, very often when you see a reference that comes in for a simple community-acquired pneumonia, patients are already on meropenem from day one for no reason. So I think we have to be very cautious about our use of antibiotics, because we ourselves are causing a lot of resistance by irrational use of antibiotics.
One more quick question, one quick comment. When you're choosing macrolides, oral macrolides are as good as intravenous macrolides for two reasons. One is the bioavailability of both IV and oral are exactly the same, unless the patient is vomiting so much that they can't keep in the tablet. You would like to avoid the IV clarithromycin, because the clarithromycin intravenous macrolides are very, very, very irritable. So they cause severe thrombophlebitis, and they need to be really dissolved well, which most people will not do. So unless the patient is vomiting too much, there's no point in giving intravenous macrolides. It's more or less the same as oral.
Correct. Great point, Sushmita. In fact, one point, since you have brought this up, is that clarithromycin should ideally be dissolved in 500 ml and not the regular 100 ml, which is a usual dose that happens for other antibiotics. And this is something that a lot of people don't realize.
And also, Pratibha, that doing a allergy test for them to look for this thing is invariably comes back very strong allergy to that. So actually, it's not recommended to check for sensitivity for clarithromycin and azithromycin if they are used IV. And in fact, I think as Sushmita said, unless and until the patient is unconscious, you are not sure about the absorption, there's no need for it actually. On oral, you never check. But I know that lots of ICUs keep checking for the these drug sensitivity, and then they find that it is highly sensitive, cannot be used. Actually, these are not the salts which can be actually used for doing a drug sensitivity by doing a intradermal or intradermal skin test. So it should not be done actually. And that is further deterrent to us to not to use IV and to use orally actually. In most of the patients, you can use orally.
Correct. Great. Can we move forward, Tanya?
So the patient did receive injectable antibiotics. So she received cefuroxime 1.5 gram IV twice daily for 3 days, and injection clarithromycin 500 milligrams IV twice daily for 3 days. The cefuroxime was then converted to tablet cefuroxime as sequential therapy for 4 days. So she received cefuroxime for 7 days in total. So our next question is, what other investigations and microbiological workup should be done in hospitalized CAP patients?
Okay, I think Saurabh he had logged in, but I think there's a major problem with his network. So Sushmita, back to you again, please.
So investigations wise, let's talk about bedside investigations and when to do so. As we've already spoken, that as soon as a patient comes in and has symptoms of community acquired pneumonia, the first thing we do is check their oxygenation, and that's how we decide whether they're going to need monitored versus non-monitored bed. Then we do a chest x-ray. So lots of people rush to do CT scans. CT scans are not indicated routinely at all as per most guidelines and our Indian guideline as well. A chest x-ray is good enough to show whether it is lobar distribution, whether it's bronchopneumonia, whether it's complicated pneumonia, whether there's a fusion along with that or not. So those are things that can be told by chest x-ray. And as should be the norm, as soon as the patient comes into the emergency and you decide the patient needs admission, within the first hour, you should take off samples for culture. And when we say what samples should be taken, so you've taken off the patients if they are expectorating a sputum culture, a blood culture. These are the two cultures you should be sending off, and then starting the first dose of antibiotics. So that should be the norm, and that's what you should be teaching your juniors in the accident and emergency or your emergency department, that send the cultures away within the first hour and give them the first shot of antibiotic. Tanya's asking, what do you do after the patient has been admitted? How do we monitor them? So there are few things that we do. So it's the total count or the complete blood count usually that we check to see if the TC total count, the WBC count, which was raised, whether it is coming down or not. Certain biomarkers we talk about, which are C-reactive protein and serum procalcitonin. So serum procalcitonin in bacterial pneumonias is usually more than 0.5, but it's a very expensive test and it is not indicated to be done routinely. So C-reactive protein can be used to see whether it is coming down. Usually on admission, C-reactive protein halves by 48% if the patient is getting better. So it's a cheap method and we do it in most hospitals. You would look for what the initial culture showed. You won't do recurrent chest x-rays while the patient is in, because it takes about 3 to 4 weeks for consolidation to resolve. You would want to do a chest x-ray if the patient is getting more breathless, or if you are suspecting there could be a pleural effusion, an empyema, or a pneumothorax along with it, any complication of the pneumonia. Other than that, you wouldn't do a chest x-ray, but you would monitor their blood pressures, you would monitor their saturations, you would do a CBC and C-reactive protein. And if they are expectorating now, maybe send off a sputum culture if the patient isn't getting better. Just now, Dr. Talwar was talking about, PCR testing and non-microbiologic testing. Those are expensive and at this particular point of time reserved for severe CAP patients where you want a quicker result, and that maybe we can talk about later.
Okay. I think Sushmita has... Dr. Talwar, you're on mute.
One point to add, which Sushmita has very nicely highlighted. Actually, there's no point in running to the CT scans, because if we have already done the X-ray and started the treatment, there is no hurry to do it unless and until you are expecting a complication or something which you are not able to see on the chest X-ray. In fact, there was a beautiful study which tried to, in the ER itself, they took all patients, they did the X-ray as well as the CT scans. And they found that although they could pick up 23% extra pneumonias on the CT scan, but the most important thing was that it did not make any difference on the treatment part of it, because they were all being treated for the lower respiratory tract infection anyways. So it did not add anything specifically. As far as the this thing is concerned, molecular test, which I think Sushmita said we'll discuss later, that when should we, because now there are so many biofires available and these are very randomly being used by physicians, and then very difficult to interpret and treat the patients with those kind of reports. So I think we'll go to that later on, Pratibha.
Yes.
Just one more point. Is I forgot to mention, if the patient presents with atypical features, has hyponatremia and has been somewhere out and has been on a visit somewhere and develops, and you're suspecting Legionella infection, then urinary Legionella antigen can be checked.
In fact, our Indian guidelines do not talk about it. They say that whenever it is suspected, you do it, as Sushmita has said. But ATS and other guidelines in the West do recommend to do these tests. And obviously, there is a different reason for giving it, because there the tests are not so expensive as the rest of the treatment, but here the tests are also very expensive. And you have to always remember the TAT, like turnover time for the test which you are asking for.
Correct.
If you wait for that much to start the specific treatment, and the most of the time treatment is clinically suspected, whether it is a Legionella where we are suspecting, because Streptococcus anyways you are considering as the most common cause of community acquired pneumonia, and you are going to treat that. You are going to anyways cover for Streptococcus. So only I think Legionella, what Sushmita says, makes sense. And especially if you have abnormal liver enzymes, hyponatremia, you have more constitutional and systemic symptoms, or there's a patient who gives a history where he's likely to be exposed, then go ahead and do a Legionella, because then it will make us a sense to perhaps use fluoroquinolones, which we generally try to not use it at all otherwise.
Great. So, moving forward, Tanya.
So, ma'am, the next question is, what is the difference between non-severe CAP versus severe CAP?
Sushmita?
Yeah. So non-severe CAP. So we're talking about community-acquired pneumonia. CAP is severe, isn't it? So non-severe CAP is one which is either patient treated in the outpatient department or in a ward-based department where monitoring is not required. As soon as monitoring is required for pneumonia, it becomes severe. Now, when it becomes severe, what we need to find out is whether it is a CAP that is getting severe, or is it a hospital-acquired infection which is complicating a patient who has come with CAP. So severe CAP is any pneumonia which needs monitoring, which needs early diagnosis and quick management, because overall mortality turns very, very high if treated, or if it is diagnosed later. So whether it is a HAP or a CAP will all come out on the diagnostic panel. But severe CAP is one where you need to monitor the patient and investigate and treat them as soon as possible.
Okay. Let's move forward, Tanya.
So, ma'am, when do we discharge a patient with CAP?
So usually any patient who has been admitted with a community-acquired pneumonia has been started on treatment. If they have been requiring oxygen, they are off oxygen and they are afebrile, eating and drinking well for at least 48 hours. That's when you can switch over from intravenous antibiotics to oral. And if they have enough support at home, discharge them.
Great. So as Sushmita has said, I think this will vary from patient to patient, and there is no fixed time period saying 3 days, 5 days, 7 days. It will all vary from patient to patient, the severity of the pneumonia at the time of admission. Yes, go ahead, Tanya.
So, ma'am, the next question is, what is the most important step to improve outcomes in hospitalized CAP patients?
Yeah. Dr. Talwar would be, Sushmita, go ahead.
Let Dr. Talwar answer this.
Yeah, I think we'll give you a small break.
I think the most important thing is to start the antibiotic as soon as you have diagnosed it. So, in fact, the critical care societies have been talking about it, that, we are sometimes taking time to transfer the patient from the ER to the ICUs or the wards. Sometimes we are not giving and introducing the antibiotic because we have not been able to get the sputum of the patient. So I think Sushmita has made that very well, that if you get sputum, fine, otherwise take a blood culture and start your antibiotic. And the more and more guidelines are now shifting towards that. Even if you have not been able to take it, don't delay the antibiotics. Like previously they said give it up to 6 hours, then it became within 4 hours, now it is within 2 hours or as soon as possible. So I think the most important thing is that we should allocate the patient to appropriate place, and we should start the antibiotic as soon as possible. I think these are the two most important thing. And this is like obviously in the NHS, they have a lot of issues of shifting the patients into the ICUs. There they found that you do everything in 6 hours, and that will improve the quality of the outcomes of the pneumonia patients. And that everything means that assess them appropriately, do their X-rays, give them oxygen, give them antibiotic, and get them prioritized to wherever they need to be, whether it is a non-ICU or ICU related admission. I think this all makes a difference, basically.
Okay, great. There's a couple of questions in the chat box. There is a question, I think, which has already been covered, which said if a patient is responding to given antibiotics, at what frequency would we repeat X-ray and blood routine? I think Sushmita has already mentioned that we do not need to keep repeating X-ray if the patient is already responding, unless there is a deterioration in the clinical condition or the oxygenation. Saurabh is back here. Saurabh, would you like to add something? I think the moment I ask Saurabh a question, he gets logged off. Unfortunate. So, yeah. And of course, blood workup. At the time of admission, you are doing a blood workup. Sushmita has already elaborated about CRP is a quick, cheaper marker to suggest, but it's nothing. There is no recommendation to keep repeating it. Or, I mean, I normally would not repeat, do daily investigations. I know often in certain ICUs, there are protocols that you keep doing daily CBC, keep doing daily CRP. I don't think that needs to be done unless there is a deterioration in the patient's clinical condition. Yes, Saurabh, would you like to add anything to this?
Hi, ma'am. Yeah, so many times we have seen in the ICU that the patient keeps on getting investigated on a daily basis. But I guess we need to be a little bit more pragmatic and more reasonable whenever we are doing a patient's X-ray or in terms of doing the blood.
Yes, I guess he was just agreeing with what has been spoken already. So there is a question here is what are the drugs given in triple therapy for the treatment of MRSA? Dr. Talwar, would you like to take this one?
Okay, so the drug of choice is a vancomycin, basically, and of course, we have two more choices, that is teicoplanin and linezolid available if we are talking about MRSA. But linezolid is again one of the reserved drugs, basically, which we do not wish to use in these situations. So teicoplanin is the one, but the role of teicoplanin and its penetration in the lung has been always a subject of controversy. But yes, in some of the guidelines, it is already there. But the drug of choice is actually a vancomycin. I do not know, Sushmita, what would you say on that?
Yeah, vancomycin or teicoplanin.
So teicoplanin is easier for us to give. So that is why everyone is on to teicoplanin to use, but use it in appropriate dosage. That is the most important thing for teicoplanin.
Correct. And again, linezolid we want to reserve as pulmonologists for our patients. Okay, moving ahead, Tanya.
And that is the end of this presentation.
Okay, so there is a question from Dr. Narendra who's asking what if the X-ray is normal, but clinically and pathologically it is community-acquired pneumonia. So, Sushmita, would you like to please take this one?
Yeah. So lots and lots of times it takes on radiological appearances take a few days later. But if the patient is, presenting with symptoms of fever, purulent sputum, tachypnea, and confusion, you would still treat it as a lower respiratory tract infection, just that you would not label it pneumonia till you've seen it radiologically. But you would treat it exactly the same way as Dr. Talwar said. You investigate the person, immediately send off cultures and start them on empirical treatment for in chest infection. Pneumonia is just a radiological diagnosis, and maybe you would do radiology a few days later and that would appear. In most atypical pneumonias, there is always clinico-radiological dissociation, and you don't wait for radiology to appear before treating.
Great. Another question is, what antibiotic would you escalate to if this patient was not responding to our initial line of management? Dr. Talwar, any thoughts on that?
So I think if this patient at the day 2, we find that 48 hours and the patient is really not responding, the most important thing is to not consider that the antibiotics are not working, but to consider that what are the other causes that this patient is not responding. So is it that he's got a pleural effusion or an empyema which is developing up? Is it then only you go for a resistant? But by then, we would have already got our some culture ideas what is growing on that, and would like to tailor the antibiotic therapy according to that. But yes, then if still this all is not available and things are really not doing good for the patient, you really need to take a call that escalate the antibiotics on those things. So in those situations, you would only think of gram negatives in India, because in Indian ICUs, the most common bacteria which is causing has been isolated in most of the centers after the streptococcus pneumoniae, and in fact, some of them even not streptococcus pneumoniae, because it's very difficult to grow. The gram negatives are seen, and Klebsiella is a very important one, which is generally grown. So you need to cover a Klebsiella for that. So you need to go on to actually a cover where you will be using a third or a fourth generation, where you have a combination with a beta-lactam and a beta-lactamase inhibitor, and covering for a resistant Klebsiella will be something which will be required, because this is what we see from community in India basically. But before that, we'll be very sure that there's not something else which is causing fever not to go and clinically patient not to become better.
Okay. Great inputs. Can we move on to the other case? Dr. Rahul, would you like to share your screen, please?
Great presentation by Tanya, though.
Yes.
Sure, ma'am. I'll start now.
Yes, please.
Is the slide visible, ma'am?
Yes.
Okay, fine. So, good evening, everyone. Today we have a case of community-acquired pneumonia, and we shall evaluate how to go about this case. Now, coming to the case, we have a 67 years old female, class 1 obese, who has presented to the OP with fever, with high-grade fever, with cough, with scanty sputum production, not so much, and some symptoms of upper respiratory tract involvement, like a runny nose and some discomfort in the throat. There is no shortness of breath as such. She is a diabetic on oral hypoglycemic agents. Personal history: she is an ex-smoker, and occasionally she consumes alcohol. She is housewife, and she recently had a travel outside the country. On examination, she is looking mildly sick, coughing frequently, mostly dry. She is febrile with a temperature of 100 degrees Fahrenheit, and her oxygen saturation is low. It is 94% on room air. She is not hypotensive. Respiratory rate is on the higher side, which is around 32 breaths per minute. Throat is congested, tongue is dry, and occasionally there are rhonchi over bilateral sides. Uh, this is the X-ray. We can definitely see a patch here. And now we come to a $1,000,000 question, which is, should this patient be admitted in a hospital? So, over to you, ma'am.
Yes. Good case. Sushmita, what do you think? Would you like to admit this patient?
Yes, definitely. I would like to admit this patient. First of all, she is above 60. Second of all, she is obese. Third of all, she has diabetes. And fourth of all, she's just been outside the country with features of viral symptoms presenting. And the chest X-ray definitely shows abnormality.
Okay. So we have this various criteria to decide admission, which we have discussed in the previous webinar about how to stratify the patients. Dr. Talwar?
Yeah, so in the last seminar we discussed, because there are plenty of them available actually. So, CURB 65 or CRB 65 is generally considered because it is easy, it can be easily done, and it doesn't take much efforts. The other ones like pneumonia severity index or ATS criteria or some other ones are very complicated, and generally, it takes a lot of time to do it, and most of the ICUs may not be able to perform it. This thing. CURB 65 is actually more in telling us, what is the predicting the mortality of the patient. So and obviously it is biased towards the age. So if somebody is young, they will not be able to get good CURB 65 to get into the hospital, and that kind of a confusion can happen sometimes. And anybody who's like 70 or 80 will be immediately put to CURB 65, where the score will tell that they should be straight away admitted to the hospital. The other ones are there, but ATS is the one which has been widely used abroad and the rest of the places. But because it was very complicated, so I think they have tried to make it abridged, where they have knocked off actually 3 parameters, that is the WBC count, platelet count, and hypothermia. And they found that the sensitivity and the specificity still remains that. So if you have anybody who's hemodynamically compromised, requires vasopressors, oxygenations, or in any kind of a mechanical ventilation or non-invasive mechanical ventilation, straight away goes into the ICU. That's an easy way to do it. But I think these questions are very relevant, Pratibha, when we are talking about public sector hospital, where getting an ICU bed is almost impossible.
Correct.
They really need to prioritize your patient who really needs to it and go into more criterias to see. And of course, as Sushmita has very rightly brought out, that comorbidities is a very important aspect, whether this patient is going to deteriorate in next 48 hours or not. And there is already a data to suggest that if we assign them wrong place at the first go, then even changing the scenario later on after 48 hours does not improve their outcomes. So in fact, if the patients who deteriorate on the floors and then they are shifted to the ICUs, they don't make it so well as if they would have been otherwise if they were assigned the right place. So I think that is the most important thing. And PSI is a good one, but PSI is a little difficult to perform. ATS ITSA is the more simpler ones and more this thing, but every hospital has its own set of criterias for the admission which is there. But ultimately the idea of admitting the patient and assessing is that what is his chances of mortality there. So if obviously there is a chance of high mortality, the patient has to be put into an appropriate care where we can actually decrease the mortality there. That's a very important aspect. But rest to Sushmita.
No, absolutely. Agreed.
Okay. So moving forward, Rahul.
He's mute. Rahul, you have to unmute yourself. I think that there are certain issues there again, I think. Rahul?
Okay, so I'll put the question.
Pratibha, because last time also in the diagnostics it was discussed
How
that
to
when the patients come,
correct.
how do we decide whether it is bacterial pneumonia or a viral pneumonia or both are together in an individual patient? Because practically we are seeing a lot of overlap these days. So that was the question. Sushmita, I think Sushmita can take this question again. I think because this is for the, I think, more revision kind of a thing for all of us.
Yeah, so absolutely. I think the most important question becomes when the patient comes into the emergencies, whether it is viral versus bacterial. So usually bacterial pneumonias, they are quite quick. They happen, they will tell you that I was well a couple of days back and then I started having fever, I started having a lot of cough and purulent expectoration. So usually there will be some expectoration or purulent expectoration in bacterial pneumonia, but constitutional symptoms such as headache, body ache, joint pains, etc., are lacking in bacterial infection. Viral infections, however, they will not have very high grade fevers as in bacterial pneumonia. They kind of have lowish grade fever, but have more constitutional symptoms, more extrapulmonary symptoms such as headaches, such as body aches, such as sniffling, such as upper respiratory symptoms, as this lady presented with. Those are usually the symptoms that you find when the patient presents to you. And when you start examining the patient, you will usually find, bronchial breathing in bacterial pneumonias, whereas physical findings are sort of normal or very minimal in viral findings. When you do a chest X-ray in bacterial pneumonias, you will find a lobar sort of presentation, whereas in viral pneumonias, it's bilateral and minimal infiltrate sort of presentations that patients present with.
Rahul, can you move on to your next slide?
Sure.
This has been already discussed. I think
Yes.
we can move on to the next slide now. What was this?
How do we go about treating it in an OPD basis?
Yeah, Sushmita, please.
I think we've discussed this also in that beta lactam in the OPD. The outpatient treatment guidelines are, if the patient has no comorbidities, then you can either use just a macrolide or doxycycline. 100 milligrams twice daily for 5 days. But if the patient has comorbidities and has mild pneumonia and has been treated in the past 3 months, then you can use, a beta lactam and a macrolide as you would use in a patient with comorbidities and mild pneumonia.
So actually what it means is, Sushmita, that apart from one fact that this patient is not so sick, one antibiotic alone may be enough.
Yes.
But if there are comorbidities, you use 2 antibiotics and these 2 remain same. Only thing is, if he is admitted, it will get intravenous. If he is not admitted, you will get oral.
Orally.
And drugs have got a good bioavailability, so you can treat them with the similar things. So there's no separate choice for particularly antibiotics. Antibiotics would remain the same. The seriousness would only dictate the admission and the intravenous route, perhaps more importantly in these situations. And this is actually why I brought this ATS exercise, because they recommend levofloxacin. But as Sushmita said, recommended dose is 750. It is not 500. That's the one point. But then we have issues with the fluoroquinolones, and that we have already discussed.
Okay. So moving forward. Yes, I think we've already covered this already. I think we have covered this also, right? We've just covered this, when to suspect co-infections also.
Yes.
I think this is a good question, that when to give antivirals. I think this is a very good question.
Yes. So antivirals randomly are not really required if the patient is presenting within the first 5 days of their symptoms and has a proven influenza, or say for now even COVID is going around quite a lot. COVID, you really don't nearly need to treat. You need to give supportive care at the moment. But if it's influenza A or B that the patient is presenting with and has comorbidities along with that and is within the first 5 days and is febrile, then it is absolutely okay to give them oseltamivir first of all, and look for any signs of coexisting bacterial infection and treat them with antibiotics if those are present. So how would you know whether there is coexisting bacterial infection or not? That would be, again, by the symptoms that we talked about: high-grade fever, purulent phlegm, and underlying structural lung disease or underlying comorbidities. That's where you would give. If it's purely viral symptoms that the patient is presenting with within the first 5 days, and your C-reactive protein and CBC are lowish with a low-grade fever, it's safe to give only oseltamivir to start with, but keep a very low threshold to add antibiotics if they are not improving or develop symptoms that are suggestive of bacterial infection.
Correct. So to just
guideline, Pratibha, which had come actually, in 23, and this is entirely changed because of the, the scenario of viral infections in the last 3 years, because the previous guideline was in 2019 before the COVID, and now this guideline, and especially what has happened is all over the world, influenza has taken over with a big bang actually, and most of the ICUs are full of influenza pneumonias rather than the COVID pneumonias. So that is why they said that, if you should test it, do PCR. And if the season is correct and you don't have PCR facility, then you can still cover it. So I think my question here is that, sometimes patients keep asking us, even the physicians would say, what's the point in actually, doing the test? You just give them oseltamivir. So my take is that it has its own side effects. It's not that safe drug. Sushmita and Pratibha, you both also opine on random use of, I think, or rather, empiric use of an antiviral like oseltamivir.
Yeah, so I think it's not a great drug to tolerate as well. With my own experience of having used it last month, it's not a great drug to tolerate also. It does have a lot of GI side effects and stuff. So I think unless there is strong evidence, also there is, if you have other comorbidities like you have renal disease and all, there are some dosing issues and, renal nephrotoxicity as well. So I think one thing is that if you are strongly suspecting it, if it is the season, if the patient has started with a viral-like illness, or as we have said, if there are bilateral infiltrates, which are not dense consolidations, things to suggest that there is a coexisting viral, then one would think of it, but not randomly in every patient. Definitely not.
Yeah, I completely agree. Especially in mild influenza without comorbidities, in the first 3 days, the fever goes as it is. It has a lot of GI side effects, and it should just not be recommended randomly to treat somebody. But yes, if you are suspecting pneumonia and high comorbidity, and you can't do a molecular test for them, then yes, go ahead, but explain that there will be GI side effects.
And even a neuropsychiatric side effects are reported with oseltamivir.
Yeah.
And once in a while it happens, but I know that when it happens, it becomes very, very frightening for the patient because it's a simple drug given for innocuous disease, which otherwise would have got also well. So there's really no point in them. If the patient has severe community acquired pneumonia, patient has landed up in the ICU, then you are actually more justified to use it. If this is a like influenza, like you don't have time to wait, and you're seeing that like the period which we had last month, almost everybody was coming influenza.
Yeah.
So in those situations, it would make effect, but otherwise, we need to remember the side effects.
Okay. Rahul, so I think, Rahul, you're on mute. I'll just pose this question for you. So when would we give steroids in pneumonia and for how long?
So steroids in pneumonia again are not given upfront at all. It is not recommended in any guidelines, including our Indian guideline. But if somebody has severe pneumonia with septic shock, that's where that would be one indication to use in the intensive care unit in a hemodynamic unstable pneumonia in the dose of methylprednisolone 0.5 milligram per kg body weight in two divided doses for approximately 5 to 7 days or till they become hemodynamically stable to gradually taper. Or if this was a patient who had pneumonia along with acute exacerbation of their airways disease, where you would give it again in the similar kind of dosage with cover of antibiotics, with cover of adequate bronchodilation for the patient. Other than that, there are no other indications to give steroids in pneumonia.
Great. So we can move forward. Sushmita has already elaborated on this. So this is a good question, which will, I think, solve a lot of questions in the chat box about the investigations. How does procalcitonin stand in the management of community-acquired pneumonia? Sushmita, please.
Okay. So procalcitonin is number one, an expensive investigation. Number two, is not available everywhere. And number three, you don't get it back straight away in most hospitals. So as Dr. Talwar said, the turnaround time is high. So procalcitonin can be used where you are wanting to differentiate between a bacterial versus a viral pneumonia, sometimes in some specific group of patients where less than 0.5 is usually unlikely to be a florid bacterial pneumonia. It should not be used as a biomarker to monitor pneumonia, but it can be used where you're wanting to stop antibiotics. Suppose you have a procalcitonin upfront, which is high, and you want to know whether to stop the antibiotics early or not, and if procalcitonin has come down significantly, it may guide to stop antibiotics, but it should not be used to monitor pneumonia. That is not recommended in the guidelines.
Okay. Moving forward. Rahul, yes.
Very good question which had come was in the chat box is that we should do blood cultures in ICU with pneumonia and fever. So I think that question is a very good question. Every patient should have a blood culture actually, but blood cultures are positive only in maybe 30% or less than 30%, 20 to 30%. But this should be done because this patient is severe community acquired pneumonia. That is why the patient is in the ICU. If the patient is in the ICU, then we should do the blood culture actually. There is a recommendation to do the blood culture.
Okay. Another question in the chat box is, if the patient has desaturation, what is her choice, doses and duration of steroid therapy? I think that the steroid therapy has nothing to do with the desaturation or the hypoxia, unless it is a patient who has underlying airway disease, who has a coexistent exacerbation. The steroids, as Sushmita has elaborated, is only when for treatment of septic shock.
It's the hypotension which determines the steroids, not the hypoxia.
Hypoxia. Yes. Okay. So to wind up, any take-home messages, Dr. Talwar?
I think Shushmita will be able to give quick key messages today.
Okay, I'll do what you say. So, yeah, I think from my point of view, if I'm suspecting somebody has pneumonia, I need to diagnose the patient as quickly as possible. I need to assess if the patient can be treated at home or whether they need to be treated in hospital. So risk stratification needs to be done immediately. I need to send away cultures before I start antibiotics as soon as possible within the first 1 or 2 hours of hospital entrance, and then I need to start them on antibiotics as soon as possible. When I've started them on antibiotics, my job doesn't finish. I need to monitor if the patient is responding well or not clinically, as well as along with that, looking at their saturation levels, their blood pressure levels, and their CBC and C reactive protein at certain intervals. If they are not improving, then I need to repeat cultures and I need to escalate treatment. If it is a hospital acquired infection that I suspect, then the local scenario or the bacterial scenario should guide empirical treatment while you're waiting on the cultures that you have sent. And you need to treat the patient with adequate medication, with adequate dosage for an adequate amount of time, which in most uncomplicated pneumonias is 7 days or so. Once they are eating and drinking and have been afebrile for 48 hours with improvement of their symptoms, they can be discharged home on oral antibiotics. Chest x-rays, unless it is a complicated pneumonia, need not be repeated within 4 weeks. So they can review an outpatient department after 4 weeks with a repeat chest x-ray, a CBC and a CRP to see what they are doing. If they have comorbidities or they are above the age of 65 and they've had a pneumonia, you should always recommend them to have pneumococcal and influenza vaccination. And if they are diabetics, then to ensure that the diabetic control is good enough. That would be my take-home message.
Great. I think most of the points are covered. Yes.
It's really almost everything has been covered very well. I think my only thing which I want everyone to perhaps take it home and pass it on is that it's not the choice of antibiotics. It is the choice of how you give them and whether you allocate them rightly or not. And that should save the life, because still we have got millions who die of pneumonia every year, actually. So I think right patient, right antibiotic, right time is everything important in this situation, and that we need to look at.
Correct. Okay. So I thank Tanya and Rahul for great presentations. And Sushmita, of course, I think she had to do the sole job of being the discussant. Thank you so much, Sushmita. And Dr. Talwar, as usual, you summarize the situation very well and take over whenever needed. So our next session is going to be on 14th of May, and we are going to start the series on COPD, right? So hope to see all of you all there going forward. And thank you all of you for joining us on a Saturday evening. Good night.
Good night. It was great.
Thank educational partners, which is the Glenmark, which is helping us in organizing them and passing it on to all physicians across India. We are on YouTube, we are on Twitter. You can go on API website, you can go Indian Chest Society website, and you can just log in indianchestsociety.org, and it will be on Facebook, YouTube, everywhere it is there. And it is also archivable. So if you have missed previous episodes, then you can always retrieve them and see that there is a definite thread with which it is going. How to diagnose in OPD, how to take care of them in the OPD, how to take care of them if you admit them, when to refer them. Practically all questions are answered. And Pratibha is going to take next month on COPD. So it will also cover the entire spectrum, the COPD diagnosis, their management, exacerbations, controversies. We will be trying to take it all to our physicians across India. Thank you everyone for joining in. Thank you, Sushmita. Thank you, Tanya. Thank you, Rahul. And thank you, Saurabh. And above all, many, many tons of thanks to Pratibha for taking her time to do it every second week she's doing these seminars, getting time to do it, and putting so much of efforts. Pratibha, we have no words both from API as well as Indian Chess Society, because you have been nominated by both the societies to carry on this webinar.
Thank you. Thank you, Dr.
Thank you.
Talwar.
Thank you.
Bye. Thank you. Good night. Good night. Bye.